Neurology quiz number 70. What are the mechanism of action, uses, side effects, and dosing of levetiracetam or Keppra and brivaracetam or Briviact? Levetiracetam is an anti-epileptic drug used for the treatment of focal seizures, myoclonic seizures, and generalized tonic-clonic seizures. The oral form is FDA approved as adjunctive therapy for focal seizures, myoclonic seizures, and primary generalized seizures. Although not approved for monotherapy in the United States, it is widely used as first-line treatment for focal and generalized tonic-clonic seizures and is approved as initial monotherapy in Europe. It is the only AED with Class 1 evidence for efficacy against myoclonic seizures. The IV formulation is used off-label for the treatment of status epilepticus. The mechanism of action is not clearly defined. It is thought to act by binding the synaptic vesicle protein 2A or SV2A, which results in decreased neurotransmitter release in a state of neuronal hyperactivation. It is rapidly absorbed and has excellent or 96% bioavailability. Peak concentration is achieved about 60 minutes after an oral dose. It is less than 10% protein bound and does not compete with other AEDs for protein binding. It is not extensively metabolized and close to 70% is excreted unchanged by the kidneys, while the rest is hydrolyzed to inactive compounds. Half-life is 6 to 8 hours. It has no significant pharmacokinetic interactions. With the IV form, the plasma concentration is reached in 5 to 15 minutes. The oral form is available as immediate release and extended release. For the immediate release, minimum recommended dose is 500 milligrams twice a day. It is started at a low dose and titrated up. Dose should be increased by 250 to 500 milligrams at 1 to 2 week intervals. Usual maximum recommended dose is 3000 milligrams per day, but can be increased to 4000 milligrams per day. There are reports of seizure exacerbation at higher doses. Rapid escalation can lead to adverse effects. It is also available as a solution containing 100 milligrams per ml. The extended release is started at 1000 milligrams per day and can increase every 2 weeks by 1000 milligrams per day to a maximum of 3000 milligrams per day. Therapeutic levels range from 12 to 46 micrograms per ml but can vary slightly from lab to lab. For status epilepticus, dose used is 1000 to 3000 milligrams IV or 60 milligrams per kilogram. The maximum dose is 4500 milligrams. Modification of dosage for impaired renal function is as follows. Creatinine clearance more than 80, dose adjustment not required. Creatinine clearance 50 to 80, 500 to 1000 milligrams POQ12. Creatinine clearance 30 to 50, 250 to 750 milligrams POQ12. Creatinine clearance less than 30, 250 to 500 milligrams POQ12. Dialysis 500 to 1000 milligrams POQ day, then 250 to 500 milligrams supplemental dose after dialysis. Side effects. Neurobehavioral side effects are most common. These include headache, drowsiness, fatigue, and generalized weakness. Psychiatric side effects include hostility, anxiety, depression, and less commonly psychosis, hallucinations, and suicidal thoughts. These side effects improved with decrease in dose or stopping the medication. GI side effects include nausea, anorexia, vomiting, and abdominal pain. Cardiovascular manifestations are increased blood pressure in children. Hypersensitivity reactions are rare, but those that can be seen include anaphylaxis, angioedema, and Stevens-Johnson syndrome. Pregnancy and lactation. Prolonged experience in pregnant women has not identified increased risk of major birth defects or miscarriage with Keppra. Literature includes data from pregnancy registries and reflects experience over 2 decades. It is excreted in the breast milk and levels in infants have been found to be low. Levetiracetam is an analog of Keppra. It also binds to SV2A but with a 20-fold higher affinity, and its penetration into the brain is higher than levetiracetam. It is FDA approved for the treatment of focal seizures both as monotherapy and adjunctive treatment. It has excellent bioavailability after oral administration and weak binding to plasma proteins. It is primarily metabolized by hydrolysis in the liver and then excreted in the urine. It can interact with other AEDs. It can increase carbamazepine epoxide levels and may increase phenytoin levels by 20%. It is available in oral and IV forms. The dose is 50 mg PO BID, which can be increased based on tolerance and response to a maximum of 100 mg PO BID. Dose adjustment is not required in kidney disease, but it is not recommended in end-stage renal disease patients on dialysis, as there are no data in this patient population. In case of impaired liver function, the starting dose is 25 mg PO BID and maximum dose is 75 mg PO BID. Most common side effects are somnolence, dizziness, fatigue, and irritability. Depression and suicidal ideation can occur but are uncommon. Some studies suggest that behavioral side effects from levetiracetam can improve after switching to levetiracetam.